More pleased than to introduce my good friend and colleague, Steve Higgins. Steve is director of the University of Vermont College of Medicine Center on Behavior and Health, principal investigator on the NIDA FDA Ph.D. award in tobacco regulatory science and vulnerable populations. So to be clear, that's 2 Senate grants. He holds the rank of professor in UVM's Department of Psychiatry and Psychology and serves as vice chair of psychiatry. He's got a lot of awards. He served important roles. He was president of CPDD. I always like to watch Steve because follow his work, if not him specifically. And let me be clear, we met at the Utah State University. We met this other guy, Ken Silverman, who was just here recently. And Steve said, "It's not happening here at Utah State University. I'm going to University of Kansas." Well, Ken and I say, "That's a good idea. We'll go too." Then Steve gets into behavioral pharmacology and goes to BPRU at Hopkins. I go some other place at UNC for a little bit. I said, "I think I'll go up to Hopkins too." Steve moves to Vermont. A little bit later, I moved to Vermont. So I always like to follow him, but I also like to follow his work. So a couple years ago, Steve got into health behavior, and lo and behold, now I'm starting to do health behavior. So I always like to see where he's going because I know where I'll be going next. He's been remarkably productive. He received an NIH Merit Award. He's contributed a ton to the field, has made important seminal observations on the role incentives in producing behavior change, and I look forward to hearing his presentation today.
Well, thanks a bunch. Thanks, Warren, for that generous introduction, and you know, it was very reciprocal. Believe me, that's a very one-sided story, and as I'm sure you know, Warren is one of the most creative researchers I have ever met, and so working with him over the years was just an absolute blast. And so we still continue, even though we're not at the same institutions. That's why I'm here today. So anyhow, let me get going on this. So I'm going to be talking about, as you see, cigarette smoking in rural women and tobacco control and regulatory interventions to decrease smoking. All the research I'm going to show is team research, and so I want to just be sure to acknowledge my excellent faculty collaborators, our trainees. We have Tyler here. There's Tyler in the audience. Excellent research staff and generous research support, and I have nothing else to declare besides the research support. So as you know, and you're studying them, as Warren just mentioned, but the U.S. lags far behind other industrialized countries on major measures of health status that you see here. And when population health experts look at that situation and ask the question, where could we make improvements, there's a real consensus that it's in the area of personal behavior, lifestyle, where we could make changes and get big improvements in these population health indicators. And when you hear what they're talking about, it makes good sense. So we're talking about things like tobacco use, other substance abuse, physical inactivity, unhealthy food choices, and so those sorts of behavior patterns increase risk for these chronic diseases and others. And then the one that I'm focusing on today, cigarette smoking, remains the leading cause of preventable death. And 480,000 in the US and 7 million globally. And during my visit here, we were chatting, some of us, about this. You know, we're just desensitized to these numbers because these are staggering numbers. This is an outrageous epidemic that we're still in, and we need to do better. And so that's what I'll be talking about. So smoking, we have made tremendous gains. So we're at, according to the National Survey on Drug Use and Health, which depending on the survey you get slightly different estimates, but about almost 21% of the U.S. adult population is current smoker, and that's down from a little bit now from 2010, but a modest change from 2015. So things are kind of a little bit flat in terms of the reductions we need. And then when you look to see who's continuing to smoke, the less educated, more impoverished, sexual minorities, certain racial minorities, those with comorbid psychiatric conditions, those residing in certain regions, and in those in rural settings. Since I was coming to Roanoke, I thought this might be a topic that would be of interest, and I hope it is. And then, obviously it's not innocuous. This overrepresentation of smoking in rural residents contributes to these chronic diseases, smoking-related chronic diseases. And then overrepresentation among women is a grave concern because of the adverse effects on the woman, but also the transgenerational impacts. And so we need more effective methods. We need to understand risks better, and we need better interventions to decrease use. So I'm going to present a little bit of research. Some of you guys have presented, we're at conferences together. So I try to think of some stuff that you haven't seen before, and then the stuff that you have seen before, put up with it because it's for those in the audience who haven't seen it yet. But I don't think you've seen this. So as part of an FDA working group on vulnerable populations that I lead, we've been looking at smoking in rural areas and published a couple papers. So this was one that is looking, as you see there, geographic disparity, rural versus urban cigarette smoking in the U.S. So it's that same survey I mentioned, the NISDA nationally representative survey, U.S. civilian, non-institutionalized population. I'm sure most of you know this survey. And we're comparing smoking status defined, as you see there. You used in the past 30 days. You've used more than 100 cigs lifetime. That's a standard definition. We're looking at adults. And they're designated to reside in a rural or metropolitan slash micropolitan area based on the U.S. Census. And it's just population density. And we're going to look at unadjusted and then adjusted. And when we adjust, we're adjusting for a wide range of socio-demographic characteristics that are associated with smoking. And I think you'll find the data interesting. They go over 2007 to 14. So these are the unadjusted estimates and prevalence rates and trend lines. And so the green is the rural, and the dark gray or black is the urban. And so, that's probably not that surprising. But the surprising part is when you make the adjustment. And so in the past, you could adjust out that difference by taking into consideration socio-demographic characteristics. But now it's looking like rural status in and of itself is a risk factor that you cannot adjust out or account for the differences just by knowing the socio-demographic characteristics. So maybe in the Q&A we could talk a little bit about that. I think it's driven by economics at first, but then the economics have such a widespread influence on communities that eventually, if you have a sufficiently chronic shortage of jobs or whatnot, or low-paying jobs, it can change a whole community such that I think it becomes very difficult to adjust to account for it. All right, so we followed up that study to see if there were sex differences. So we're looking at essentially the same exact study, but now we're going to separate men and women. So the unadjusted, what you see on the top lines are the rural men, higher smoking than the urban men, but a lot of the confidence intervals are overlapping. And then the women, you see an interesting difference in that the the urban women, the bottom line, have that same decreasing trend that you can see in the others, but the rural women are actually going up. So that's a real concern. And then when you do the adjusted, it's the women that are contributing most to that gap that I showed you in the first study. And so there's further drilling down you can do on this. So that's about as far as much as I'm going to say today on this set of studies, but there is more to be kind of unpeeled or drilled down on. But then in looking at this data, we came across another observation that Tyler and I are actually doing a study on now, right now. The results aren't ready for me to present today, but it's looking at the same kind of thing you see here from the American Lung Association. This is NSDA data again. It's 2009. So we have rural women here, women of reproductive age, not pregnant, pregnant, and then same thing, urban, not pregnant, pregnant. And when you look at these differences, there's a significant interaction. So there's a steeper drop-off, or a steeper difference between pregnant and non-pregnant in the urban than the rural. And what that's about is more of the urban women are able to quit when they find out that they're pregnant than the rural women. And every day we learn something more about the adverse effects of in utero exposure. So this is this is not a minor thing that the rural women are wrestling with. But the direction is in the desired direction. So you might think that these women just need a little boost to get it. So, of course, this isn't zero, so they need a boost as well. So let's look at, something that we've been working on for about maybe the last 12 years or so that some of you have seen before, but others have not. So I want to talk a little bit about smoking during pregnancy and how you can improve cessation rates. So I've already been hinting around that cigarette smoking is among moms is a very serious public health problem. And about 22% overall of U.S. women of childbearing age are regular smokers, and about 13% of pregnant women, but you just saw that wasn't 13% among rural pregnant women. And then, these disparities by socioeconomic status. So if you think of, if you look at that figure for women or people with a GED, greater than 40% smoking prevalence. So that's like a striking. That's the prevalence where smoking was when we first found out in 1964 that smoking caused cancer. The U.S. prevalence rate overall is about 42%. So there's some groups in our population who have not benefited or not changed their behavior very much at all. But then if you look, among people like are in this audience, dramatically low rates, so graduate degrees 6% or lower. And then when women find out they're pregnant, about 1/3 of women who are pregnant or smokers when they find out that they're pregnant will put down the cigarettes almost immediately. And we've done studies, and it happens almost the same day that they get the test results. And they're very good at it. They don't pick up those cigarettes again to maybe 6 months postpartum, the relapse rates will start really kicking in. So that's pretty exceptional, but the others will smoke right on through without some sort of intervention. So the literature, we've been doing trials on this problem since the mid-1980s, and the first seminal trial, was very effective, but they did a very intensive intervention, and they decreased smoking rates by about half, and they increased birth weight, average birth weight, and smoking decreases the fetal growth. So that was a tremendous, really good way to kick off research area, but almost all the subsequent research use really brief lower cost interventions, less intense interventions, and they don't work very well. And so there's good reason why they do this, and we can talk about that. But the long and short of it is that they don't work, not nearly at the level we want. So there's a group that does meta-analyses on this problem, and there have been a lot of studies, more than 70 controlled trials, more than 25,000 women. And what you see on average when you look across studies like that is, you can detect a significant effect of the treatment at the meta level, but it's very small magnitude, about 6% against whatever you're comparing, whatever your control intervention is, about 6% better. And the exception is the one I'm going to tell you about, financial incentives, which produces about fourfold more than that. So let me quickly give you an idea from our own research how you do this, but we're not the only ones doing it. We took a program that we had developed with cocaine-dependent outpatients, these voucher-based incentives, into this population, but now it's being looked at internationally, and I'll just show you some first our data and then some meta-analysis data. All right, so I'll show you data from 166 women treated in Burlington, and we're going to look at women who get incentives contingent on them showing us that they haven't smoked recently, or they'll get them non-contingently or independent of their smoking status as a control. And in Burlington, Vermont, the women we're dealing with are primarily Caucasian, they're young, and they're without health insurance, less than 12 years of education. So they really are a disadvantaged group. I mentioned the cocaine-dependent outpatients we used to work with, and these women are more disadvantaged than the cocaine-dependent outpatients. So the two conditions are contingent incentives, non-contingent. I think Ken Silverman was here last week, so it's ditto on design. And so the women who are in the intervention condition, they get these vouchers if we can objectively verify they haven't smoked, and there's a way that the vouchers are available from. Usually they come into the studies at the end of the first trimester, and we offer incentives through 3 months postpartum, so 12 weeks after delivery, and we have a way of scheduling the incentives that certainly many of you know about, where we start low and then they escalate in value contingent on people putting together a period of continuous absence. So the mean earnings is about $461 for the results that I'll show you. A woman could earn as much as $1,100 if she abstained from the point of late first trimester through 12 weeks postpartum, but because many don't, too many in my opinion, we're only paying out this much. And then in the non-contingent condition, make a long story short, we keep the amount of material resources we're giving the women the same. That's the reason that the women have trouble. They're disadvantaged, and maybe, if you could just give them a little bit of extra resources, they'd have a better chance of succeeding in a quit rate. If that's true, then they shouldn't be different in quit. So this is 7-day point prevalence abstinence. This is end of pregnancy, and the women who are getting the incentives contingently, quit rate's about 35%, and in the control it's about 7%, so a fivefold difference. And that at 12 weeks postpartum, when the incentives are still in place, both groups are showing decreases in absence, but it's still a big difference here. And same thing 12 weeks after the incentives are over. Again, still, further out you get from delivery, more women going back to smoking, but still seeing a benefit of the incentives. And then these are birth weights, and so on the y-axis here is just birth weight in grams, and this is infants born in the incentives. And then infants born in non-contingent, you could see that you shift the distribution upward by giving the incentives of getting the women to quit smoking. And then this is the meta-analysis I was telling you about. This is part of a meta-analysis on incentives in smoking generally, not just for pregnant women, but they have a subsection on pregnant women, and that's what we're looking at here. So this is the trials that they met their eligibility criteria, some of them from us, but some of them from others, including this bigger trial over in Scotland. And then this is the overall odds ratio for quitting, collapsing across all these trials. So there's about, it increases almost fourfold the odds that, the incentives increase almost fourfold the odds that a woman would quit during the antepartum period compared to whatever the no incentive control condition is. All right, so the new research that we're doing on this topic is going to mothers of young children. So they're, again, predominantly women who are economically disadvantaged, and we define young children by as below 12 years of age, because they are still spending a lot of time with mom. And so if mom's a smoker, they're getting secondhand smoke exposure. Let me see what I want to say. So we want to develop an efficacious, cost-effective intervention. These are all Medicaid-insured moms. I already mentioned the age. We recruit them from the community, and we're going to do the incentives. And then they're not pregnant, so we're doing pharmacotherapy as well. And we're going to do a combination pharmacotherapy, so they get a nicotine patch, so a longer-acting nicotine replacement therapy, and then they also get gum. So it's the patch is to kind of keep the blood level stable, and then if they have a period of craving or something, they can use the gum, and there's evidence to suggest that that's effective in disadvantaged women. Okay, so and then we're going to look at whether I'm not going to report on this today, but whether by getting the moms to quit, you can objectively demonstrate reductions in exposure in the children. So I think that probably, and essentially the incentives are just like what I told you about in the pregnant women, except we're just going to do it for 12 weeks rather than carrying it as long as we did with the pregnant women. And there are 3 treatment conditions people are randomized to. Best practices, which is the 5 A's in the Vermont quit line. That's pretty standard stuff. Or best practices plus the incentives that I was talking about, or those 2 plus the dual nicotine replacement therapy. And we use, we objectively verify smoking abstinence. We use the same kind of schedule. And if a woman was continuously absent through 12 weeks, she could earn about $800. I think that's... So here's what we have. These are preliminary data. At the end of the 12-week intervention with best practices, very, very poor quit rates. This is a Medicaid population, notoriously hard to get to quit smoking, and up around 40% when you have the incentives, but not really any difference between the incentives plus NRT versus the incentives only. The 3-month follow-up, there's a little blip upward in the control condition, and these guys are coming down. But by 9 months follow-up, that is not sustaining. And these guys are doing pretty good, so that's quite a bit different. So this is 9 months after the end. So we're following them for a year. This is 9 months after the end of the 12-week intervention. All right, so I just want to quickly say that this problem of smoking among women and the problem of disparities in rural women is not specific to tobacco. There are other health behaviors that are also a problem that we're researching. One is unplanned pregnancies. So Sarah Heil is leading research in our group looking at a behavioral economic approach to getting opiate-dependent women, a really tough group to work with, to use medically approved contraceptives, which are long-acting reversible contraceptives. And I'll just tell you, that she has dramatic impact. She incentivizes, she has a combination of the World Health Organization where you make the contraceptives available on site. If a woman wants an IUD, she can get it that same day, and that's all medically okay. And then she incentivizes the women to stop in if they're having side effects and talk about any adjustments that need to be made. They don't receive incentives to use the contraceptive for ethical reasons, simply incentives to report any side effects and discuss them. And she has dramatic increases at the end of the intervention. About, I think, almost half of the women in the incentive plus World Health Organization intervention are on a medically approved contraceptive, and it's about, I don't know, 8% or something in the women in the control condition, and there are about 20% of the women in the control condition have had an unplanned pregnancy versus 0 in the intervention condition. So dramatic impact. And then this is Diane Galeman. Our group is leading this study and trying to get Medicaid patients to go to cardiac rehabilitation. That's a validated secondary prevention intervention to keep people who have had a recent heart attack or a bypass surgery from having a second or a repeat event. And in the 3 years following cardiac rehab, it decreases hospitalization rates and it decreases mortality rates. But Medicaid patients, even though Medicaid would pay for it, Medicaid patients don't go. And that's pretty, it's almost like signing a death sentence. So what Diane has shown, what Diane has shown is that you use the same kind of 12-week intervention I just showed you with the Medicaid moms who smoke, and you can double completion rates of cardiac rehab. All right, so when we're dealing with these, looking for ways to impact these health disparities, we have to keep in mind that the majority of people never get formal treatment. And so we need other ways to try and impact these same problems. And I want to transition to trying to impact cigarette smoking through tobacco regulations. And the one that we're researching, we have a FDA, NIH-supported T-course, Tobacco Center of Regulatory Science, and our T-course is focused on reducing the nicotine content of cigarettes to below an addiction threshold. All right, so in a way of background, some of you are quite familiar and some probably unfamiliar. But in 2009, federal legislation was passed that gave the FDA regulatory authority over tobacco products, including the nicotine content of cigarettes. And they set up 15 centers around the U.S. to give them evidence they need to do evidence-based regulations on different topics. So our specialty is addiction in vulnerable populations. So FDA has authority to reduce, although not eliminate, nicotine content in cigarettes and other products if they can make a case that, an evidence-based case, that doing so would protect public health. And this all follows this concept of reducing the nicotine content below an addiction threshold. Started with this essay in 1994 by Henningfield and Benowitz, two tobacco researchers many of us in the room know and respect. And they just said, hey, if we know nicotine is constituent in cigarettes that produces addiction, and we know that it's a drug and drug effects are dose dependent, you almost always, why don't we just find a dose that's too low to do it? And you know, the reason you can't go to 0 is because of the politicians in tobacco growing states. But they, at this point, they have the opportunity now, finally, after many years following the publication of this essay, to have a look at it. And so there are studies in relatively stable and healthy smokers. That's where the research started, as you would expect, that support the feasibility and efficacy, and I'm going to show you a little bit of that. And then what we're doing is taking this concept into these vulnerable populations, people who have other kinds of comorbid conditions. So the study that's probably the most influential study in the healthier smokers is this one that appeared in New England Journal in 2015, led by Eric Donnie and colleagues. You can find Benowitz in here, and then Dorothy Hatsukami is a collaborator of Warren's here. So very prominent tobacco researchers. And they did this double-blind, multi-site randomized trial, large number of smokers, 840, and they get randomly assigned to 6 research cigarettes or their usual brand for 6 weeks. And the range of cigarette doses go from this high level of 15.8 milligrams of nicotine per gram of tobacco down to this very low level. So this is the level that's in many commercial cigarettes now. And then this is the level that's below the hypothesized threshold by Benowitz and Henningfield. I think many of you know this, but this is not the same as light cigarettes. So what we're doing here, then in those cigarettes, the nicotine content remained the same in light and full flavor cigarettes, and it was just the ventilation that was manipulated, so kind of the engineering of the cigarette. And people found ways of smoking that they could still get the nicotine out of the cigarette. And here, the tobacco was actually modified to have less nicotine in it. So the cigarettes actually have less nicotine, and it's not just ventilation. In this study, the main dependent measure is whether cigarettes per day decrease, or what Warren cigarette purchase asked, my intensity of demand decreases, and then whether nicotine dependence decreases. And so this is what they saw. This is total cigarettes. So the research cigarettes or any of their own cigarettes that they're using during the trial, and these, their usual brand, the high dose, and then one dose, the next highest dose actually increased from where they were at baseline. And that's because they get free cigarettes, so less, cheaper cigarettes, higher rates of smoking. But those that are on these reduced nicotine content cigarettes, they do not show that increase, and actually either stable or slight decreases over. But at the end of the 6 weeks, very substantial significant decreases from what the people using the higher content cigarettes were doing. And then this is just a pre-post measure across these different doses of they did 2 different, Fagerstrom, Wisconsin, but these validated measures of nicotine dependence. And the only place where they're seeing reductions is when you get the nicotine content down to these very low doses. All right, so I already mentioned that we're interested in the same topic, but in vulnerable populations, and we look at 3 groups. Economically disadvantaged women of reproductive age. I've been showing I have great long-standing interest in this population, and we're using them as an exemplar of individuals with socioeconomic disadvantage, and that's a risk factor for smoking. Opioid-dependent individuals, we look at them. Any of you who work with this population know that they're notorious smokers, prevalence rate of 80 to 90%, and we're using them as an exemplar of people with comorbid other substance use disorders, and then individual with affective disorders, and them as an exemplar of people who have comorbid psychiatric conditions. And then we're doing 2 sequential multi-site studies. First one was a within-subject clinical lab study, and there we're looking at acute effects for research cigarettes, and we're using like classical measures of addiction potential, the way that you measure any pharmacological agent to see whether it has addiction potential and relative to like some sort of standard. And then a second trial, a second random multi-site study that is a clinical trial. And here people are getting, like the Donnie et al. Study, they're getting randomly assigned to to one of the cigarettes that they stay on for 12 weeks. So the acute effect study is completed and published, and the clinical trial is ongoing. So I'm going to show you some data from both studies. And so this is the acute effects study and the completed one, so the results are published. And there are no differences between the populations. So the economically disadvantaged women are responding the same as the other populations. So I'm just going to present them as a group. But this is an intervention that could potentially lower smoking in that group of women that I've been talking about throughout the presentation. All right, so these are the numbers. This is within subjects. There's 169 smokers across these different populations of interest. They do 14 2 to 4 hours sessions within subject design, I've already said. They always come in with a baseline breath carbon monoxide level that's about half of where it was at baseline. So they come in ready to smoke. And then these are the research cigarettes we looked at, so they're the same as those that Donnie et al. Were looking at. Everything's under double-blind conditions. So in the early sessions, they're going to sample the cigarettes in separate sessions. So they come in one day, and we give them one of the research cigarettes, and we say, we want you to, this is cigarette A, arbitrary letter code. We want you to sample this. You can smoke how you normally smoke, but you got to use this filter, and we have them smoke through a press device so we can measure smoking topography, but how the puff duration, how frequently they puff is up to them. And then after they smoke the cigarette, they either do the cigarette purchase task, and they do some other subjective effects measures. And the CREST device allows us to measure smoking topography so we can tell whether they're adjusting their smoking with the lower nicotine dose cigarette to try and get more nicotine. And then in the later sessions, we want to directly test the relative reinforcing effects of the different doses. So we're going to, under double-blind conditions, we're going to give them across separate sessions dose pairs. So we're going to take all the possible dose combinations here, which is 6 different dose combinations, and let them show us which of these cigarettes they would prefer to smoke in a 3-hour session where they're free to smoke as much or as little as they want. And then I'm just going to, of all the different measures, I'm just going to focus on the concurrent choice and the cigarette purchase task results, because they're the two that most directly get at the reinforcing effects of smoking, which is the major determinant of abuse liability. So the concurrent choice results, the way we have is when they have these dose pairs, these are the dose pairs, and then this is the proportion of choices, and what we're looking at is whether they're going to allocate their choices more to the cigarette that has the higher dose, higher nicotine content, which is the lighter blue, versus the lower in the dose pair. And the way we have these organized is starting with the biggest difference between the two cigarettes, going down to the small differences. And what you see is there's very, very strong evidence that they are making choices based on nicotine content. They always prefer more nicotine versus less nicotine. So if you're looking at what we're interested in, whether lowering the nicotine content reduces the relative reinforcing effects of smoking that cigarette, the answer is emphatically yes, based on this data. And if you had to answer how low should you go, the answer would be as low as you can, I think. And that's what this dose represents. So enough about that. And then this is cigarette purchase task data. So there are 5 indices that many of you know about much more than me, but we have here So demand intensity, how much would they smoke of these different cigarettes if it didn't cost them anything? And then what about the max expenditure in a 24-hour period by dose, the max price or P-max, and then the break point, where the point at which they said if I had to pay this price, I would just quit smoking, and then overall elasticity. So you get dose-dependent changes in 4 of the 5 indices in the direction of the lowest dose having significantly less relative reinforcing effects or lower demand than the higher doses. All right, so now just a preliminary look at the control trial. And so this is data that we took a peek at for the competing renewal on our center grant. And knowing I was coming down here and want to show you something, from the trial, I figured I would share that since reviewers saw it. So it isn't, but anyhow. And then, yeah. So just know that the graphics could be improved, but this was in the grant, and I just took a screenshot of it. So essentially it's total cigarettes per day, just like in the Donnie et al. Trial. The filled symbol is the 15.8, the level representative of current commercial cigarettes, and this is the lowest dose at 0.4 milligrams per gram of tobacco dose. And the disadvantaged women, opiate-dependent affective disorders. If you look at the women, they start out, smoking the 2 cigarettes at a similar rate, and then the low dose goes down, and the high dose actually goes up a little bit. And the same thing in the affective disorders. The opioid-dependent guys, we thought that they might be a little different. They weren't in the acute, but yeah, largely they're the same in the acute exposure, but it takes them a while to, I think they're more tolerant. It takes them a while to get clear on what they're going to do here, but then you get separation. So both of these effects are statistically significant, but these guys, I think, because it took them a while, not so. And the same thing on the nicotine dependence measure. Significant reductions in nicotine dependence in these 2 groups, not quite in this group, but headed in the same direction. So I think all 3 of them are going to benefit from a reduction in nicotine content cigarettes, and it may be that these guys get a little bit greater benefit than these guys, but I think, and that's what the FDA wants to know, would this policy offer benefit to these more difficult, more vulnerable populations, and our data suggests yes. So then just to wrap up, I think we all are in agreement about this. Cigarette smoking is a tremendous public health problem, differentially impacting these disadvantaged populations, including the one I want to underscore for you guys because they're right here in your backyard, the rural residents, multi-generational effects. We need better ways of getting these more vulnerable populations to quit smoking. I showed you the efficacy of financial incentives as one way with one of these populations, but I think it could be helpful in other vulnerable populations. But it's not a silver bullet, and it's not the only way we could innovate, but I think we need to innovate, is my point. And then I think we also need to keep in mind that besides clinical interventions, we need other kinds of interventions where we can reach the many people who will never get a formal clinical intervention. So I'll stop there.
Well, I can start, right? So
Yeah.
Ken was just here, and when he was tackling some hard groups, he says, I'm just going to pay them, a much higher magnitude, right? And showed some impressive results. So I presume that with any of these populations on the CM part, right, that you could get even higher rates of abstinence.
That's right, yeah. And we certainly think about it, and so, you get such pushback about offering any incentive, so you're always trying to get a reasonable effect size without too large an incentive. But I think the final arbiter is going to be cost effectiveness. So I'm not happy that we only get less than, we don't even get half the women that quit. So it's way better than what is considered routine care or best practices in this population now, 4 times better, 5 times better, but still less than half. So we, in the current trial, have made an adjustment where we doubled the incentives in women who smoke 10 or more cigarettes. So women who have higher man intensity. And we're doing better in them, but it's not, so we get what Ken has shown. You double the magnitude of the incentive, you get more than you got before, but you're not getting everybody. I think a reasonable parametric question would be, why not take it as high as you can reasonably take it and see where you can get and work back down, and we just haven't done that. These clinical trials take a long time to do, and we need more people funded to do them, but that's not happening at this point. But there is, you saw the meta-analysis, there is international interest in this because there's nothing else that we know that works very well with them.
Speaking to that, the data with the interaction of incentives and nicotine replacement
Yeah.
therapy, it looked like nicotine replacement therapy, like, that addition was not that much more helpful. So I wonder if you could speak a little bit.
Yeah, that's thanks for the question. It's a very interesting thing. And the trial is still ongoing. We're not blind under the cigarette trial, the nicotine content trial. So, we know the results, and so I didn't mind sharing them even though they're preliminary. So a couple of things that are interesting about it is the NRT doesn't seem to do much. That's just what I'm seeing now. But the women who didn't get the NRT get e-cigs on their own. And yeah, and so we're tracking that. But it's not a formal part of the study, but it may be that a combination of incentives and e-cigs would be a much more effective intervention in this population. And so that I want to see how it plays out. But it was an unanticipated development, and I think it could be exciting. Yeah. Nick.
In the last study, you showed in the clinical trial with nicotine cigarettes, like in Dorothy Americana's study, the separation between the conventional nicotine strength and the reduced nicotine strength, but they're still smoking an awful lot of the reduced nicotine cigarettes for quite a few weeks.
Yeah.
The sense that it's just taking a while, they would eventually quit, or was it sustained forever, or?
Yeah, my sense in this population, but it may be not unique to this population, but in these populations we're working with, I'm not convinced that they are going to just flat out quit because we take the nicotine content. So I think it's going to be more like Shahan's single exposure, when they didn't have a choice between the reduced and the high. But I think it would make it easier to quit. And so, and the data is supporting that, not in ours yet, but in the Donnie, Hatsukami, and the other studies, that there's more quit attempts. They have lower dependence level. The smoking rates are coming down. So I think the control by the reinforcer is weakened. So if they choose to quit, they would have a higher likelihood of success. And then the idea is, could we do this policy complemented by ready availability of non-combusted sources like e-cigs. And then what you're looking for is like in a concurrent choice, where they say, if this is the only thing available, I would use it, but if you're going to make these e-cigs where I can get, high amounts of nicotine like I like, I think I'll go over to that. And so that's where I think the thinking is coming, that simply taking the nicotine content available down by itself isn't going to be enough to get these more recalcitrant smokers to give it up. I don't really know. I'm sure we are. Yeah, I'm sure we are, but I have not looked at it. I'm sure we ask them everything that they use. In fact, they have to call us every day with the what's this system called? The automated. You know, they call a recording every night and tell us everything they smoked. So you know, I think that's what we've been talking during my visit here about. The FDA policy that they're developing this comprehensive regulatory plan. They are carefully reading the science and trying to think through how to develop a nuanced policy that considers the kind of interactions or whatever you want to talk the context, the important influence of context. So we shall see.
So if we go back to the very beginning with the epidemiological
Yeah,
data,
yeah.
and that the women are reaching parity with the rural men.
Yeah.
Do you have any? Are there any clues about what's driving that?
I don't really know yet scientifically. My hunch is that they are maybe worse off economically than any of the other groups there. And that kind of leads into the community. We're getting these, you and I talked about a little bit, these economically segregated regions. And if you're around, so where these populations see a lot of other smokers, where among us, you know, in terms of anyone we know, we might go weeks without being, you know, hanging out with a smoker. But if you're around a lot of other smokers, then you're more likely to smoke, and there's some data to indicate that. So, like, you know, we're social primates, so I think that's a factor. Yeah, I think that's about as far. There's this book that I've mentioned several times during my visit here, the Geography of Jobs, that's taken a look at this and taken a look at how basic economics have changed in the U.S. over, you know, say from the latter part of the last century to now, and there is this segregation by socioeconomic status, where rural now is starting to mean more than just living out in the country. And then there are also other factors where less enforcement of regulatory regulations. So, you know, there's more violations of advertising and sales to minors and stuff in less densely populated areas where just less monitoring. So that's, we don't know, but that very well may fewer tobacco control cessation opportunities. So fewer resources directed at being healthy.
So given that they're poor and given that they're choosing to smoke, and cigarette smoking is fairly expensive in most places, not too much in Virginia, but many other places, are they just smoking at a reduced rate, or are they banging away at it?
Oh, that's an interesting question. That smoking has gone down in terms of the number of cigarettes people smoke per day, but what has not gone down is the exposure levels. So they smoke the hell out of them. So yeah, that's a good question. You know, and the other irony is that you know, a lot of these rural states tend to be in politically more red states, and then those red states are more inclined to be in the direction of small government, fewer resources, of the things we're just talking about. So I think there is like a you know, kind of a snowballing effect where people who could benefit most are, you know, just look at who took Medicaid expansion. You know, and so there is a real thing going on, and it's having a far-reaching impact on our country politically, but the one that we pay most attention is in health. And, you know, I'm focused on tobacco, but it's not specific to tobacco. We have the explosion of the opioid epidemic, and it's really hitting a lot of these rural states like yours and ours.
I think our time is up. Let's
Yeah,
thank Steve for one talk.
Thanks.